introduce our next speaker, Lil, who's with us, Lil Valentin. Lil Valentin is professor in University of Lund in Sweden. I think most people know Lil, but she's obviously also a key part of the IOTA study, and that's, in a sense, the hat which she's wearing today. And Lil is going to talk about IOTA terms and definitions. IOTA is the International Ovarian Tumor Analysis Trial. And this is an important talk because I think in gynecological ultrasound in general and ovarian masses in particular, it's really important that we speak the same language. And so I'm going to hand over to Lil, who's going to describe or talk about how you should describe adnexal pathology. Thanks, Lil.
IOTA terms and definitions. How should you describe an adnexal mass? In this lecture, I will discuss with you this consensus statement, which was published in the year of 2000 by the International Ovarian Tumor Analysis Group, the IOTA group. This is a consensus statement on how we should examine adnexal masses, how we should measure them, and which terminology we should use to describe our ultrasound images of adnexal masses. Why do we need standardized terms, definitions, and measurements? We need them for many reasons, but one important reason is that we need to understand each other in our daily clinical practice. If I say there is a multilocular solid lesion, it should mean the same to you as it means to me. If I say there is a papillary projection, it should mean the same to you as it means to me. And if I quote the size of a papillary projection, it should mean the same to you as it means to me. That is, measurements should be taken in the same manner, irrespective of who takes the measurements. So now I will go through with you the definitions of the most important IOTA terms. The IOTA definition of a lesion is part of an ovary inconsistent with normal physiology. This part of this ovary is not consistent with normal physiology. It's a Sertoli Leydig cell tumor. And this part of this ovary is not consistent with normal physiology. It is struma ovarii. And here we have a large, solid adnexal mass, not consistent with normal physiology. So all these three structures are lesions. This, however, is not a lesion because this is a hemorrhagic corpus luteum, and a hemorrhagic corpus luteum is consistent with normal physiology. The IOTA definition of a solid component is a structure that has echogenicity suggestive of tissue, such as myometrium or ovarian stroma, and all tissue is potentially vascularized. This means that the round white ball in a dermoid cyst, which consists of hair and sebum, is not a solid component, because a ball of hair and sebum is not tissue that can be vascularized. It is amorphous material. A blood clot or a lump of mucus is also not a solid component, because a blood clot or a lump of mucus is not solid tissue that can be vascularized. Sometimes, however, it can be difficult to discriminate between amorphous material and solid tissue. And then there are some tricks that we can use. We can push upon the lesion with the vaginal probe or with our outer free hand. And then it sometimes happens that these suspicious structures, they lift, move away from the cyst wall and start to swim freely in cyst fluid. Then we know we are not dealing with solid tissue, but with some type of amorphous material. For example, a blood clot or a lump of mucus. And sometimes when we push upon a lesion, the suspicious structure starts to move in a jelly-like fashion, as you can see here. True solid tissue does not move in this way. This is not solid tissue. It is not a solid component. It is a blood clot. Another trick that we can use to discriminate between true solid tissue and amorphous material is that we can switch on the color Doppler function of our ultrasound system. If we then can clearly see blood vessels inside the suspicious structure, we know we are dealing with solid tissue. However, if we cannot detect any color Doppler signals in the suspicious structure, we still don't know if we are dealing with solid tissue or amorphous material, because the reason why we cannot detect any color Doppler signals can be purely technical. Maybe our ultrasound system is not sensitive enough to detect slow velocity blood flow. Maybe our Doppler settings are wrong, or maybe the lesion is too far away from the ultrasound probe for it to be possible to detect slow velocity blood flow. Another trick that we can use to discriminate between true solid tissue and amorphous material, in particular a blood clot, is to look at the contour of the suspicious structure. If the contour is clearly concave, as you can see here, it is probably a retracted blood clot. True solid tissue usually does not have a clearly concave contour. If after you have applied all these tricks, you still don't know if you are dealing with solid tissue or with amorphous material, you should classify the structure as solid tissue, that is, as a solid component, because worst case scenario always rules. The IOTA definition of a papillary projection is protrusion of solid tissue into a cyst cavity with a height of at least 3 millimeters. Protrusions of solid tissue with a height less than 3 millimeters are not classified as papillary projections. But of course, all papillary projections are solid components, because by definition they consist of solid tissue. They are a subgroup of solid component. This, however, is not a papillary projection, because this solid tissue does not protrude into the cyst cavity. When we use the IOTA terminology, there are 5 types of lesion. A unilocular cyst is a cyst with one cyst locule, no solid components. A unilocular solid cyst is also a cyst with one cyst locule, but there are also solid components, and the solid component can be a papillary projection, as you see here, or some other type of solid tissue, as you can see here. A multilocular cyst contains septa, but no solid components. A bilocular cyst is also classified as a multilocular cyst. A multilocular solid cyst is a cyst with both septa and solid components, and the solid components can be either papillary projections, as you see here, or some other type of solid tissue. A solid tumor consists of at least 80%, 80% solid tissue. So you scan through the whole volume of the tumor and you estimate whether or not it consists of at least 80% solid tissue. Shadowing. Here are examples of shadowing. You can have shadowing behind a ball of hair and sebum in a dermoid cyst. You can have fan-shaped shadowing in a fibroma, and you can have shadows behind papillary projections, for example in serous cyst adenofibromas. There are 5 types of cyst contents. Anechoic means completely black. Low level means a few spread echoes, and ground glass echogenicity is the echogenicity that we typically find in endometriomas. Hemorrhagic cyst contents, like in hemorrhagic corpus luteum cysts, and mixed cyst contents, as we see in dermoid cysts. Ascites. The IOTA definition of ascites is that there is fluid above the pouch of Douglas. The IOTA color score is based on subjective estimation of the color content of the tumor scan. A color score of 1 means that there are no detectable color Doppler signals in the mass. A color score of 2, that there is a minimal amount. A color score of 3, that there is a moderate amount. and a color score of 4 that there is abundant color. And of course, when you estimate the color content of the tumor scan, you must adjust your Doppler settings to maximize detection of slow velocity blood flow without artifacts. In most ultrasound machines, a pulse repetition frequency, PRF, of 0.3 to 0.6 kHz is optimal. Then you increase the Doppler gain until you see the artifacts appear, and then you decrease the gain until you see the Doppler artifacts just disappear. Measurements. How do we take measurements using the IOTA measurement technique? We should always measure 3 orthogonal diameters, 3 diameters at right angles to each other, and we should take our measurements where we estimate that the structure that we want to measure is at its largest. So if you want to measure the size of an ovarian cyst, you first obtain a longitudinal section through the cyst and you measure its length and its anterior-posterior diameter on that sagittal section where you estimate that the cyst is at its largest. Then you turn your ultrasound probe 90 degrees to obtain a transverse section through the cyst, and you measure the width of the cyst on that transverse section of the cyst where you estimate that the cyst is at its largest. When you measure the height of a papillary projection, you should not include the thickness of the cyst wall or the thickness of the septum from which the papillary projection arises. You should measure down to the inner cyst wall. Now, if you forget, how can you practice and update your knowledge? You can go to the IOTA website. There you will find a lot of educational material, and this is also where we announced our web-based IOTA certification courses. Thank you very much for having listened to me. I will be able to take questions at the end of this session.
Dear Lil, thank you very much for this very basic explanation and elucidation of very important terminological issues, which is correctly named, can be correctly treated. Thank you very much. I have one question about bilocular cyst. Bilocular is equal to multilocular according to IOTA terminology. In the updated ORAT's classifications, we have changing approaches, attitude to this bilocular cyst. It's considered to be definitely benign, and they put it in the category of ORATS 2. What do you think about this classification of bilocular cyst?
According to the IOTA classification, it is a multilocular cyst, but I agree most bilocular cysts are benign, but I don't know if the risk of malignancy is as low as in a unilocular cyst, because we know that in a unilocular cyst with smooth walls and largest diameter less than 10 centimeters, the risk of malignancy can be estimated to be less than 1%. At least it is not higher than 1.1%. But I cannot tell you the risk of malignancy in a bilocular cyst. We haven't looked at that in the IOTA group.
Okay, thank you. And one more question I have. How do you prefer to report dermoid cysts in your ultrasound protocol, in your report? As dermoid cyst or mature teratoma? How to call it?
In the template that we have in our clinic, it is dermoid cyst. And what were you suggesting? Mature teratoma or?
Yeah, mature teratoma.
Cystic teratoma?
Yeah, mature teratoma. I met this idea to call it like this, like mature teratoma.
Yeah, I think when we say dermoid cyst, I think we are thinking about this cyst with hair, sebum, structures from the skin, but mature teratomas can also contain other tissues. But I don't know if it makes a big difference, actually, if we call it dermoid cyst or mature teratoma. I don't know if anyone else has an opinion on that.
I think
What do
it's
you
fair. I mean, I think I'd agree. I'm not sure it makes a huge amount of difference personally. I think I can see that they're not actually interchangeable, but in the context of an ultrasound report, I think sometimes it depends on who you're talking to as well.
think? What?
We say dermoids generally, I have to be honest. I
Yeah.
mean, and we do. I think that we have to move on. I think you're introducing the next speaker, Ines.
Yep.